Medical Service Company has made treating patients with sleep disorder breathing a top priority. That's why we created MSC Sleep, a division with a commitment to invest in technology, clinicians, and processes to create a best-in-class experience for our patients and partners. At MSC Sleep, you get the best choice in CPAP. Our MSC Sleep program provides expedited care to ensure patients receive their critical sleep therapy fast, high-touch clinical care resulting in industry-leading compliance rates, individualized communication for both the patient and the provider, offering transparency from prescription to PAP therapy, and finally, a team of sleep coaches to assist the patient through their sleep journey. On behalf of Medical Service Company and all our partners for this event, we hope this forum provides you information leading you to create even better care for sleep disorder breathing patients everywhere. To learn more about our MSC Sleep program, please visit us at medicalserviceco.com/sleep therapy.
Good morning. I hope you enjoyed the first session. Our next session will be presented by Dr. Nader Mina on the care of patients with neuromuscular diseases. Dr. Mina currently serves as Medical Director for Sleep Evaluation Services at Beaumont Health in Royal Oak, Michigan. He is also the Director for Southfield Sleep Operations and serves on many various committees. At Oakland University, William Beaumont School of Medicine, he works as an assistant professor and clinician in the Department of Internal Medicine, Pulmonary, and Critical Care Medicine. In addition to working in both hospital and academic setting, Dr. Mina has a pulmonary critical care and sleep medicine practice at Beaumont Health in Royal Oak. He is a member of the American Academy of Sleep Medicine and has several publications and presentations in pulmonary, critical care, and sleep medicine. We are pleased to welcome Dr. Mina to our educational forum and appreciate his participation and lecture. Dr. Mina will be taking questions from you after his lecture, so please enter questions under the Engage tab above the presentation screen. As a reminder, please be sure to complete and submit an evaluation after each lecture.
Good morning, everyone. Thank you for inviting me to speak in this educational event. My name is Nader Mina. I'm the Medical Director of the Sleep Evaluation Services at Beaumont Health in Royal Oak, Michigan. And today we'll be talking about the care of patients with chronic neuromuscular respiratory weakness. First of all, I don't have any disclosures. And these are the objectives of our talk today. As you notice, we'll be talking about respiratory neuroanatomy, general respiratory issues in patients with neuromuscular disease, sleep problems in patients with neuromuscular diseases. We're going to go over some specific neuromuscular diseases as well as how to evaluate these patients, and big part of the lecture will be spent on management of these patients. Let's go ahead and start with some discussion about the respiratory neuroanatomy. As you see here in this slide, this summarizes the neural control of our respiration, starting from our central nervous system, where you have the central and peripheral chemoreceptors going to the spinal cord, going to our nerves, receptors, as well as the muscles. This slide shows you more in details our respiratory muscles, or the muscles that are responsible for the process of respiration. On the left side here, we see in blue, we see the core muscles that are responsible for the process of inspiration. Specifically, they are the diaphragm and the external intercostal muscles. On the right side of the slide, you see in purple, you see the muscles that are responsible for the process of expiration. And the core muscles include the diaphragm also, as well as the internal intercostal muscles. If you also notice here, there are accessory muscles on each side that will allow us to take deep inspiration as well as do forced expiration. This is one of my favorite slides that I usually like to show my patients when I'm talking to them during the first visit for evaluation of pulmonary neuromuscular diseases. The slide basically has 4 components that work together to produce the process of respiration for us. That usually starts with the central nervous system, where we have the signal to start breathing. That will require a patent airway or breathing passages that you see here, going to the lungs, which I always call them for the patient, to understand, is basically the filters, where they inflate and deflate, allowing for extraction of oxygen and removal of the carbon dioxide. On the far right, we see the 4th component, which is the respiratory muscles. So based on this slide, as we see, we need our muscular component for our filters or our lungs to perform their function properly, which is in improvement of the gas exchange by eliminating carbon dioxide and extracting oxygen. So as you see here, we need a brain signal, we need a patent airway, we need filters, and we need the muscles to move these filters. Let's talk a little bit about the general issues that we encounter in patients with neuromuscular disease. What happens to our respiratory systems when the patients get affected by neuromuscular diseases? So first of all, we do experience weakness of all our respiratory muscles, all the groups, including inspiratory muscles, expiratory muscles, as well as the upper airway muscles. This will result in inadequate ventilation, nocturnal hypoventilation, bulbar dysfunction, and ineffective cough. And let's talk a little bit about each one of these components. So inadequate ventilation, which means those patients have problems eliminating carbon dioxide, a process that we call ventilation. This is primarily due to the weakness of our inspiratory muscles group. As a result, we have significant reduction in the tidal volume. And to compensate for this, these patients usually increase their respiratory rate. As a result of this, we'll have increase in the carbon dioxide. Subsequently, we'll have drop in the oxygen, as we call it hypoxemia, which is related to hypoventilation, as well as regional atelectasis or partial collapse of some areas in the lungs. How do our patients present? Usually they present with breathlessness, or we call it dyspnea, orthopnea, inability to breathe when they are in supine position. They also have rapid and shallow breath. They also use now their accessory muscles of respiration to maintain their breathing. How about bulbar dysfunction? This is mainly due to the impairment of the upper airway muscles. Patients usually present with dysphagia, difficulty swallowing, dysarthria, difficulty to talk, difficulty with mastication, facial weakness, difficulty controlling secretions, nasal tone of the speech, as well as protruding tongue. Going to the ineffective cough. When we look at our cough mechanism, really, it's a very complex mechanism that includes function of our upper airway muscles, inspiratory and expiratory muscles. So if we take a closer look to how do we cough, we'll find that our cough is actually, we find that our cough has three phases. The first phase is called the inspiratory phase. This is when we use our inspiratory muscles to take a very large tidal volume. And then there is the compressive phase. This when we start actually closing our airways, and then we build significantly high positive intrathoracic pressure. And then finally, we have our expiratory phase, where we actually open the breathing passages, and then we have a high peak expiratory flow. So as you see, three phases for the cough: inspiration, build up the volume, pressurize the thoracic cavity, and then expel this at a very high flow rate. So this slide also summarizes some of the sequences that we see in our respiratory system with muscular disease, starting by weakness of the muscles, followed by ineffective elimination of carbon dioxide. This is what we call ineffective ventilation. That leads to sleep disturbances, followed by ineffective cough. These patients will start suffering from problems clearing their respiratory secretions. They will have difficulty in swallowing, and they will progress to chronic respiratory failure. Let's now talk in more details about what happens during sleep in these patients with chronic neuromuscular disease. So before we start talking about the effects in sleep, I think it's reasonable to it's helpful to talk about a little bit of physiologic changes that happen during sleep. So usually the way we control our breathing when we are awake, there is a behavioral control, which is coming from our cortex that tells us we are awake, continue to sleep. In addition to the metabolic control, which is mediated by our pH, oxygen, and carbon dioxide pressures. However, when we transition from wakefulness to sleep, we lose the behavioral control, so our sleep becomes more unstable because it's only dependent on our metabolic variables, specifically our pH, our oxygen, and carbon dioxide pressures. What happens to our respiratory or upper airway muscles during sleep? There is significant reduction in the dilator muscle tone, which keeps our upper airway open, so there is increase in the collapsibility, so our airways are more at risk to collapse during sleep. There is also reduction in the activity of our accessory muscles of respiration, which will result usually in decrease in our tidal volume and subsequently decrease in our minute ventilation. This slide summarizes all the physiologic changes that happens in normal individuals during sleep, which includes reduction in their minute ventilation by about a liter. There is also a reduction in the pressure of the oxygen pressure by 3 to 10 millimeter mercury. There is reduction in oxygen saturation by 2 to 3%. There is increase in the carbon dioxide by 2 to 8 millimeter mercury, and also what we call the functional residual capacity, which we test in our pulmonary function testing. It is significantly reduced, especially during our REM sleep. So in general, our respiratory system is very vulnerable during sleep. That's why any weakness in our respiratory muscles will be really exaggerated during sleep due to exaggeration of our normal physiologic changes that happen during sleep. So looking now at the patients with neuromuscular diseases, what happens during sleep? There is weakness of respiratory and chest wall muscles. There is weakness in the upper airway muscles, which increases airway resistance. During REM sleep, we all know that there is a REM-related atonia where all the muscles are actually paralyzed except the diaphragm. So that really overloads the diaphragm. That's already weak to start, and that results in significant hypoventilation, which means their tidal volumes are reduced and their carbon dioxide will increase significantly. Throughout the course of the disease, that could also lead to daytime hypoventilation because those patients frequently cannot compensate enough during the daytime. Patients with muscular diseases also can have a lot of spinal deformity. They can have kyphoscoliosis, and that causes more restriction for our lungs. They also have reduced responsiveness of the chemoreceptors, so they're less likely to respond to these significant changes during sleep. How do these patients present? Usually they have poor concentration, they have a drop in school or work performance, they have nocturnal awakening, they present with morning headaches, fatigue, they present with hypersomnolence or excessive daytime sleepiness, as well as impaired cognition. This diagram also summarizes some of the changes that happen during sleep in patients with neuromuscular disease, starting from the bottom there, when we have abnormal gas exchange followed by sleep disturbances, symptoms of sleep disturbances going up to abnormal daytime gas exchange, more daytime symptoms, and that could progress to right-sided heart failure, or what we call it core pulmonary, and that can result into respiratory failure. What do we see when we do PSG on these patients? So there is significant reduction in the lung volume when they are in supine, and that will result to severe desaturation, and this is more pronounced in REM sleep. I'm sure all of us have seen this before. We see it in morbid obesity as well as in patients with neuromuscular disease. As a result of this, we have hypoventilation with marked elevation of the carbon dioxide. We see a phenomena that's very unique to patients with muscular dystrophy, which is called pseudocentral apneas. We also see obstructive apneas due to upper airway weakness, and we also see decreased REM sleep. This is a very common graph that I'm sure most of us have seen before, either in a patient with severe lung disease, patient who's morbidly obese, as well as patient with severe neuromuscular disease. This graph highlights two curves here. The first one, which is in blue, it shows the oxygen saturation, and as you see in REM sleep, there is substantial reduction in the oxygen saturation. At the same time, the dotted red line shows that transcutaneous CO2 monitor, and there is subsequent increase, in the transcutaneous CO2. So there is hypoxemia and hypoventilation, which is more pronounced during REM sleep. What about the pseudocentral apneas? So we're all familiar with central apneas. We have seen them before, and we know very well that central apneas usually happen in non-REM sleep. Pseudocentral apneas occur during REM sleep, and it is due to suppression of intercostal muscle activities. So our intercostal muscles in REM sleep, they're paralyzed, they don't work. So as a result of this, there is a shift of workload to the diaphragm that's already weak. So the diaphragm is profoundly weak, and you're shifting additional workload, so that results in complete exhaustion of the diaphragm. So that actually results in what we call pseudo-central apnea. So the diaphragm does not move because of the profound weakness and the shift of the load. Those pseudo-central apneas are characteristically happen in REM sleep, and they are more noticed in the chest wall muscles as opposed to the abdominal muscles. And as you see here in the graph, patient is in REM sleep. You see there is very, very minimal airflow, almost reaching the apnea definition. At the same time, there is complete elimination or complete cessation of effort in the chest wall muscles with very reduced abdominal wall muscles. So this is a phenomenon called pseudo-central apnea. This diagram again summarizes what all the effects that we talked about them in sleep, which starts from the left lower part here. We start with periods of REM sleep that are just fragmented sleep, increase the alveolar hypoventilation, you end up retaining CO2. There is more depression of the respiratory drive. There is severe nocturnal and diurnal hypoventilation. This will be translated to drop in the oxygen and increase in the carbon dioxide when we test them. They result in more frequent arousal, reduced sleep time, reduced sleep efficiency, sleep deprivation, hypersomnolence, fatigue, and then the circle continues to move more and more in this vicious circle. So let's talk a little bit about some specific diseases that we see in our pulmonary clinic or even the neurology clinic that is categorized as neuromuscular diseases. For the sake of this presentation, I'm just going to touch base quickly on those four diseases, which is the Duchenne muscular dystrophy, spinal muscle atrophy, myotonic dystrophy, and ALS. Duchenne muscular dystrophy, it's an X-linked disorder. It's the most common lethal muscular dystrophy. Average age of diagnosis about 5 years, and often these patients are wheelchair dependent by adolescents. There is a problem in the dystrophin, which is a protein complex that connects the cytoskeleton of the muscular fiber to the surrounding extracellular matrix through the cell membrane. Duchenne muscular dystrophy does affect our skeletal muscle, cardiac muscle, respiratory muscles too. Those patients frequently lose ambulation by the age of 9 to 11. They continue to have progressive muscle weakness, and they often present with restrictive lung disease or lung physiology on PFTs. They develop severe nocturnal hypercapnia, and that usually progresses to the daytime. They can develop cardiomyopathy, which is one of the leading causes for death, in addition to the respiratory failure too. Spinal muscle atrophy, or SMA, it's a neurodegenerative disorder, autosomal recessive. It's about 4 to 10 in 100,000 live birth. It's a motor neuron disease that causes degeneration of the anterior horn cells and spinal cord, as well as the motor nuclei in the lower brainstem. Characteristically, those patients have progressive muscular weakness and atrophy. And very important in these patients, their cognition and their mental ability is completely unaffected. So they often, due to severe muscle weakness and hypotonia, they have the frog-leg position. They have various degrees of bulbar weakness. They could have weak cry. They could have problems with oropharyngeal control. And again, strikingly, there is a discrepancy between the level of social interaction and cognition, high cognitive functions, and the lack of motor skills. So those are very active, interactive kids or young adults, but they lack the motor skills. Myotonic dystrophy is an autosomal dominant disease. We see we see skeletal muscle weakness, we see respiratory muscle weakness. However, they are usually spared in type 1. We see a lot of sleep disturbances in patients with myotonic dystrophy, and characteristically, these patients have excessive daytime sleepiness, which some theories relate this to low orexin level, which is the same substances that is deficient in patients with narcolepsy. They have muscular pain. They can also develop cardiac and endocrine abnormalities, as well as cognitive impairment. ALS, I'm sure everyone heard about it. They know a lot about it, or they heard about a patient with ALS. It's a disease of upper and lower motor neurons. Cases are sporadic, less than 5% are familial. Clinical symptoms usually very variable. However, it's very characteristic to affect the respiratory muscles, followed by also the bulbar muscles. There is very significant hypoventilation, especially in the advanced stages of this disease. and this is very pronounced during sleep. Non-invasive positive pressure ventilation has been shown to actually improve survival and also quality of life. So this is one of the diseases where actually non-invasive positive pressure ventilation has been extensively studied, and it showed really great outcome in improvement in survival and quality of life. Now we're going to start looking at how do we evaluate patients with respiratory neuromuscular disease when they show up to the clinic. Now, this slide is one of my favorites because this is a common scenario that I see in my patients when they come to me for their first pulmonary evaluation after being diagnosed with neuromuscular disease. So common statements and questions. So they always ask, Doc, I have no breathing problem. I don't know why I'm seeing you. I have no sleeping problems. I sleep very well. And a matter of fact, if this patient has myotonic dystrophy, they tell you, I sleep really well. I'm sleepy all the time. I'm ready to sleep all the time. These patients, they also tell you, I don't cough frequently. I don't even have cough at all. I'm coughless, so I don't have any cough, so I have no symptoms. And I don't go to the hospital for pneumonia or lung problems. And at the end, you can tell that they're asking really, why do I need to see a lung doctor? Now, this emphasizes the importance of counseling these patients and explaining to them really the role of our muscular or skeletal muscles in the process of respiration, which refers to the first slide that I did show in the beginning of my presentation. So some important points I actually encourage people to discuss when they see those patients for the first time is the timing of respiratory symptoms. Because interestingly, that most of these patients we have observed and we know that by the time they develop dyspnea at exertion or even dyspnea at rest, they have lost quite a bit of their lung reserve. So the respiratory symptoms, a lot of times, they actually lag after that reduction in their PFTs. So by the time they present to us, if they have respiratory symptoms, they probably are talking about 50% of their vital capacity, if not less. So late presentation, so it's very hard you should not wait until they become symptomatic. How about the respiratory muscle function? I always tell the patients when your legs are hurting you, when your muscles are weak and your arms or your leg, you can sit down and relax. You can take a break. However, when it comes to our respiratory muscles, there is really no break. You cannot take break from breathing. So respiratory muscles work all the time. And then when they start getting weaker and weaker, they continue to go into that vicious circle, and that can actually worsen the weakness of respiratory muscles. So again, the timing is delayed. You don't present until you lose significant amount of muscle function, and there is no option for these muscles to rest. At the same time, also lack of cough is actually a poor prognostic factor because weak cough increases the risk for infection because you're unable to clear secretions, increase bacterial growth, and increase risk of pneumonia and infection. And also we have enough evidence that early interventions do improve outcome. They decrease hospitalizations, they decrease the need of invasive mechanical ventilation, they delay the need for tracheostomy, and also they improve survival in certain conditions if they are implemented at the right patient for the right patient at the right time. So again, these are 4 points I always discuss with the patient, that be careful. Timing of respiratory symptoms usually is delayed. By the time you present with symptoms, you have lost significant portion of your respiratory function. Respiratory muscles don't have the option to rest. You got to keep moving and breathing. You got to keep breathing all the time. Weak cough is actually a bad sign, not a good sign that you don't cough. And early interventions do save lives and improve outcome. So what do we order when we evaluate these patients? And again, this is just a snapshot of what we have, as far as testing for these patients, but not necessarily that we have to order these tests for every patient. So we order pulmonary function tests. We order respiratory muscle forces. We order cough effectiveness, or we evaluate for cough effectiveness, whether by a measured value or by actually clinical assessment. Some of these patients will need to get sleep studies. In selected patients, we order arterial blood gases, and some patients might require chest radiography, including chest x-rays, maybe some CAT scan, depending really on the disease condition they have. Okay, let's talk a little bit about pulmonary function testing. So it's important to know that there is no single abnormality that is diagnostic for neuromuscular disease when it comes to pulmonary function testing. We have to look at all the numbers and evaluate them properly to determine whether they are pointing towards neuromuscular disease. We usually consider measuring vital capacity in supine position because, as we mentioned, those patients have more pronounced and more evident weakness during supine position, and usually a reduction in these values by more than 10% when the patient moves from upright position to supine position suggests that those patients have some muscular disease or muscular weakness. What are the findings we will see on the PFTs or pulmonary function testing? We usually see restrictive physiology. We see reduction in the maximum voluntary ventilation, or we call it MVV. And we also see reduced respiratory muscle forces, or what we call the maximum inspiratory pressure, MIP, and maximum expiratory pressures, MEP. A lot of these patients, we see normal diffusion capacity since the lung parenchyma is often normal, and unless they have significant parenchymal disease or vascular disorder in addition to this. So restrictive physiology, reduction in the MVV, reduction in the respiratory forces, which are MIP and MEP. This is a quick PFT for one of the patients with muscular dystrophy. And if you noticed here, both the force vital capacity as well as the force expiratory volume, the FEV1, are both reduced. And that gives us a ratio of 100%, which basically rules out the presence of obstructive disease. Their flow volume curves are very, very characteristic for a restrictive physiology. If you look at the last two lines of this slide, you see the MEP and MIP, which are significantly reduced. As you see, they're 33 for the MEP maximum expiratory pressure and minus 47 for the maximum inspiratory pressure, and both of them are way reduced compared to what is predicted for these patients. How do we assess for cough? There are variable methods to assess for effectiveness of the cough. I always remind people that just use your clinical sense. Those patients often don't cough. They don't generate a lot of flow. So you can easily assess this clinically. In addition, there are some measures that we can use, specifically the peak cough flow, and we use the numbers as 160 liters per minute, which indicates ineffective cough. However, also we found that patients with peak cough flow, which is ranging between 160 to 270 liters per minute, usually are at higher risk for infection. We also use the MAP, or the maximum expiratory pressure, and a pressure less than 60 suggests that this patient is at risk for ineffective cough. There are other methods such as expiratory cough flow tracing, and again, very, very important, is just your clinical evaluation. I often order the peak cough flow as well as the MAP, and then I gauge this with a clinical evaluation to basically determine if this patient truly at risk for ineffective cough and respiratory infections. Arterial blood gases, sometimes we order them to assess for the daytime hypercarbia. Now, when it comes back to the polysomnography or PSGs, surprisingly, we don't order them in a lot of patients. So we spare the PSGs in selected patients to assess for sleep disorder, breathing, and nocturnal hypoventilation. One important message here: we should never delay the initiation of non-invasive ventilation if patient meets the RAD criteria, or the respiratory assist device criteria. So if the PSG is needed to get additional information about sleep fragmentation, about sleep disorder breathing, you want to titrate their CPAPs, or we'll call it EPAP now, to alleviate the obstructive sleep apnea, go ahead and get the PSG. However, if your patient has definitive weakness and they meet all the criteria to initiate non-invasive ventilation, I encourage you just to initiate it directly rather than just waiting for a polysomnography or PSG to confirm this. Home sleep apnea test, everyone likes to get a sleep study at home. They actually should not be used, and they are discouraged or not indicated per the American Academy of Sleep Medicine for such patients. Let's assess also during our clinic visit, we assess the need for ventilatory support. And again, when we talk about ventilatory support, we talk about their ability to clear their carbon dioxide. So who are the patients that need the ventilatory support? So specifically patients with marked EBG abnormalities with elevated carbon dioxide, specifically during daytime, patients with severely reduced forced vital capacity at less than 50%, patient with MIP that is less than -30, those are specifically at risk for hypercapnia, and patients with MEP less than 40%, those patients usually are at risk for ineffective cough. So there is a nice rule that it's called that 20-30-40. So patients when they have vital capacity less than 20 ml per kg, or they have MIB less than 30 or -30 basically, or MEB less than 40. So those patients are at risk for respiratory failure. So really keep in mind for hypercarbia, we look at the MIB and the vital capacity. For the cough, we look for MEP. Now let's talk now about the management. So we diagnose these patients. They usually come to you into pulmonary clinic with the diagnosis of a neuromuscular disease. You start the evaluation process, and now we're going to go to the management. So what are the goals of our management for this patient? And it's very important slide that you have to highlight these goals with these patients, because certainly your interventions may not be the most comfortable intervention to start with. So if you see this patient for the first time and you tell them, here you go, this is a home ventilator, use this mask every night, use it all the time. I'm going to be monitoring you with ABGs. I'm going to do those arterial blood gases. I'm going to have you wear something called cough assist. You have to use it twice a week. And then later on, I'm going to get you a vest. So you're basically telling the patient you're going to leave with a bunch of equipment that are very bulky and big, and you're just going to fill the room with this. I don't think they're going to have good, they won't be receptive for that. So it's very important to start highlighting your goals of management before you start prescribing these equipments, and explain to them so they can buy in and understand how these devices can really improve their survival, their outcome, and they make a difference in their quality of life. So our goals of management in general would be to improve and stabilize gas exchange, improve symptoms. We can tell them that this will make you sleep better. These will make you less breathless. You'll have less breathlessness or less dyspnea. These devices will improve your sleep quality, as we mentioned. This will help you to improve quality of life, delay the need for tracheostomy, ICU admission, as well as extend survival in certain diseases. So these three circles really highlight the main three interventions that we perform in our pulmonary clinic in management of these patients, which the first one indicates the mechanical ventilation, which can be delivered non-invasively or invasively, and cough assistance and secretion mobilization. Just a quick hint about mechanical ventilation. The term mechanical ventilation does not infer which type of device you use. You can really perform mechanical ventilation with any BiPAP or NIV device. The term non-invasive and invasive, it determines how are you delivering this support to the patient. So if you're delivering this via a face mask or a nasal mask, then that becomes non-invasive ventilation. If you're delivering this support via a tracheostomy, then that becomes invasive ventilation. However, the modes are interchangeable, and we use sometimes similar modes, whether invasively or non-invasively. So let's start with non-invasive ventilation. What do we know about non-invasive ventilation? A lot of studies, several articles, a lot of literature we have showing that non-invasive ventilation in patients with muscular dystrophy, they prevent and sometimes delay the progression of chronic respiratory failure. Specifically in ALS patients, there is prolonged survival in patients with ALS when NIV is compared to standard of care. It also improved the quality of life and median survival. It also improved this specifically in patients early on without bulbar symptoms. So the key point from these studies that starting non-invasive ventilation in patients with ALS before they start developing bulbar symptoms, which basically will present with dysphagia, dysarthria, and upper airway trouble, will actually save lives and improve the quality of life. So early initiation of NIV is a key in patients with ALS. When they looked at the patients with bulbar symptoms, they found that NIV did not improve survival. However, it did improve sleep-related symptoms and some quality of life related symptoms or questionnaires. This is one of the studies that shows how the effect of non-invasive ventilation on the sleep on these patients with ALS. And as you see here, there is a reduction of the respiratory disturbance index, the RDI in REM sleep. There is a reduction in the arousal index. Also, there is improvement in quality of sleep, increase in the slow wave sleep, and increase in REM sleep. So certainly these devices to improve your quality of sleep in these patients. Important considerations I would like to highlight also about non-invasive ventilation in these patients. It always, all the time, has to be bi-level support. CPAP is not an appropriate modality of therapy or therapy for these patients. CPAP only takes care of the upper airway narrowing or obstruction. However, it will not provide the pressure support that is needed to improve their ventilation. So these patients always require bi-level support, not CPAP. Often we recommend these patients to go on a backup rate because a lot of time they develop those central and pseudocentral apneas. So they always benefit from a backup rate. We can also use volume assured ventilation, which I will be discussing in the next slides, because it can help to adjust the machine settings when the disease progresses and the patients get weaker. As we all know, proper mask interface is essential. You have a good mask, you have a compliant patient, and you will deliver your pressure. You have poor mask fitting, then you will not get the same compliance and the same effective therapy for them. Again, one important consideration I just highlighted and I would like to highlight again is do not delay NIV to perform a polysomnography. Also, in-lab titrations may not be required in many cases. A lot of the cases we start them on volume assured ventilation and we don't actually do in-lab titration for these patients. And some of these patients, because as I mentioned, this is a new invasive therapy for them, or they view this as a new therapy for them that may have difficulty to tolerate. So desensitization techniques do help a lot to improve the tolerance and adherence to therapy. And of course, we have to monitor the therapy. And right now we can almost monitor all these devices remotely, whether they're non-invasive ventilators, whether they are bi-level machines or other machines. I'm sure all of you are familiar with these devices here. They're made by the two, big respiratory companies here. And as you see, you can have on the left side what we group them as respiratory assist device, or the red, and on the right we have what we call mechanical ventilators, or they call them non-invasive ventilators. However, they're just ventilators that can work basically non-invasively or invasively through tracheostomy. This table here highlights some of the major differences. I'm sure we all have to follow the insurance rules. And as you see here, these are the codes that we use for respiratory assisted devices, as well as the mechanical ventilators. If we look at the reds, or the respiratory assisted devices, they are usually lighter in weight. They don't have a mandatory alarm. They can be remotely monitored and also controlled. So you can change the settings remotely. They all have integrated humidity. Going to the higher end, or the advanced mechanical ventilator, they're certainly heavier. Advantage, they have internal batteries, so if you lose electricity, patients still can use their devices. They can also be remotely monitored. However, to change the settings, you will need to be this needs to be done in person. One of the advantages of these devices, they can have multiple settings, so you can basically set up a daytime setting for the patient when they're watching TV, when they're resting, and also a night settings for them. They all have more advanced alarms and monitors to monitor the therapy. I'm sure all of you, or many of you, are familiar with these CMS criteria. How do we qualify a patient for respiratory assisted device? And if you start from the left side of this diagram, the documentation of neuromuscular disease, and then you need one of these three criteria, which are required by the CMS to qualify for a respiratory assist device, which is ABG, with CO2 more than 45 millimeter mercury, sleep oximetry showing less than 88% for 5 minutes, with a recording of 2 hours total. Or if you have vital capacity less than 50% of predicted, or maximum inspiratory pressure less than 60 centimeter of water. And these are basically the types of device that you can qualify those patients for. Now, when do we decide that this patient will benefit more from a ventilator, or what we call it NIV, instead of the red? Again, the principle is the same. We deliver pressure support to improve ventilation for these patients. At the same time, we stabilize the airway by the EPAP to keep their breathing passages patent. So in patients with elevated CO2, despite the use of RED, so those patients should be considered for NIV. Patients with prolonged use of device, if they're going to require this device more than 8 to 12 hours daily, so you might need to consider NIV because they have backup batteries and they're more effective ventilators. High pressure requirement or the need for daytime support, as mentioned, if the patient requires this during the daytime, then this really becomes a life-sustaining device. And with NIV machines, you're able to get the batteries, and they actually can just be used a lot more frequently than the other ones, than the RED, and when portability is required. As we just mentioned, they have internal batteries, so patients can leave the home, they leave their houses with them, they put them in their scooters, they go to neuromuscular camps with these ventilators. So certainly, if the patient has any of these criteria, you should certainly consider the initiation of NIV as opposed to RED, or if they are already on a respiratory assist device, you should consider transitioning them to non-invasive ventilation device. The next couple of slides, we'll talk a little bit about some modes that we use on the respiratory assist device, which some of the modes we know. This is the spontaneous mode. And the key difference between the spontaneous and the spontaneous timed mode is actually the time for inspiration. So if you notice in the first diagram, you have the first spontaneous breath where the patient triggers the breath, and patient himself or herself determine what is the inspiratory time. So they spontaneously cycle from the EPAP to IPAP, and they go back to the lower, to the lower pressure, which is the EPAP. So really the key feature with the spontaneous mode is patients determine what is the appropriate time to cycle and what is the inspiratory time. Versus if you go to the ST mode, it actually has a dual function, which basically in the second graph, if you look at the first curve, if the patient triggers the breath, then the patient will decide when to cycle from IPAP to EPAP, which means how long is the inspiratory time. However, if the device delivers a timed breath, then at that time, the device will determine what is the inspiratory time and will cycle depending on the cycling settings that we put. So again, first mode, patient determines the inspiratory time. The second mode, patient determines when they initiate the breath. But if you deliver a breath through the device, then the device will deliver the time. This will also compare the ST mode versus the timed mode. And as you see here in the timed mode, every breath is timed to a specific inspiratory time. So we are more in control. However, you can imagine it may not be as comfortable because when the patient triggers his own breath, I am still going to control the inspiratory time and the cycling for this patient, as opposed to the patient cycling and deciding basically about the inspiratory time. Talking a little bit about volume assured pressure support modes. These are two modes that we use usually, which is the AVAPS, which stands for average volume assured pressure support, and IVAPS, which is the intelligent volume assured pressure support. Both of them have the EE feature, which is the auto EPAP feature. Both devices, as you see, one is made by Philips, one is made by ResMed, and both of them they function in ST mode, spontaneous timed mode. They can also function in several modes. Both of them have backup rate. In AVAPS, it could be fixed or auto. In IVAPS, it's called intelligent backup rate. In AVAPS, you control the tidal volume, or you set a target tidal volume, versus on the IVAPS, you set alveolar ventilation or VA volume. In both machines, you can use either fixed EPAP or auto EPAP, and both devices offer remote monitoring. This diagram basically explains the AVAPS, how it works, and as you noticed in the EPAP graph, you see that the EPAP will adjust to maintain the patency of the airway. As you see here, it goes up and down. And the pressure support, once you hit the target tidal volume, it continues to go down. If you drop below the targeted tidal volume, the pressure support will go up. So it's an auto EPAP plus an auto pressure support to allow the patient to maintain a fixed, or basically to maintain a predictable tidal volume. At the same time, they treat their obstructive events by an auto EPAP feature. Going to the IVAPS, which is the intelligent backup rate, which basically allows the patient to continue to control their breathing. And once they drop below a certain number, the machine will take over and will bring the patient, as you see with those triangles, back to his pre-backup rate, respiratory rate here. And then once it reaches that point, then the patient will take control of the breathing. So that's actually the technology that is used by the IVAPS. If you look here in this graph, that explains to you how the alveolar ventilation could be more accurate than just targeting a tidal volume. And if you see in the middle in red here, this patient is breathing at 15, taking 500 tidal volume, and their alveolar ventilation is 5.7. If the patient starts breathing faster, then their tidal volume will be dropped, and then they maintain the same alveolar ventilation. And just kind of a reminder that your alveolar ventilation is basically your minute ventilation, which is the tidal volume multiplied by the respiratory rate. The only difference is you take away your dead space from every breath you have. So it's your tidal volume minus your dead space multiplied by your respiratory rate, and that creates your alveolar ventilation. Are these modes good or beneficial for the patients? Or why do we use volume assured pressure support modes? Again, it's very important to know that most of the labs in the sleep centers, we're not very aggressive in titrating for ventilation. We are excellent in titrating for airway closure, for obstructive sleep apnea, but when it comes to ventilation, we don't usually take an aggressive approach to normalize or actually drop our carbon dioxide. So that's one advantage of using an automated pressure support, device. Pressure requirements could change with the progression of the disease. If patient gets weaker, they get a respiratory infection, so they might require higher pressure support. So those devices, because they are targeting the volume, so their pressure support will go up automatically without the need to retitrate them again. Some of these patients, due to the mobility issues, due to the locations where they live, they may not have access to in-lab titration or to lab that performs those advanced titration. And also advancing the therapy without lab titration might expedite the process and reduce the paperwork that is needed. In general, some of the studies showed that VAPS therapies in general can improve the patient compliance because they actually adapt to the disease stage and they adjust the pressures to what actually a patient needs at this time. Again, we talked before about mask interface, which is very crucial and very, very important to achieve good adherence and compliance and effective therapy. Also, we can have the nasal interfaces. Advantages for these, they actually reduce the aerophagia. They allow oral suctioning in some of these patients. They allow some patients to call for help if needed at night, and they also work for patients who have claustrophobia. Going to non-invasive ventilation, one of the modalities, we call it SIP ventilation or mouthpiece ventilation, as you see here, which can be used during the daytime also. How do we monitor NIV, which is very important? As we said, we're going to start the therapy. We have some goals. We have some modalities we're going to start, but monitoring is very important. So all these devices right now, we can certainly obtain downloads from them. All the devices are usually connected remotely where we can actually access the device without even the patient coming to the clinic. That was very useful during the COVID, or actually it is still very useful during the COVID pandemic, where we can actually perform some televisits with these patients and obtain the downloads from the devices so we can save them from coming during the peak of the pandemic, or basically reduces the exposure for them. Certain clinics, they are equipped with CO2 monitors, which patients can use to determine the effectiveness of their ventilation. We can monitor them with overnight oximetry, ABGs, and it's very important also to monitor for complications of these devices. I'm sure a majority of us are familiar with these reports where you can actually just look at the data, look at the usage, look at the respiratory rate, tidal volumes, and then we can look at the programs that they are using. Now, when do we consider the patient as a candidate for daytime non-invasive ventilation? So everyone, I tell them that they have to use this at night and intermittently during the day if they meet one of these criteria. So if the patient continues to have elevation of the carbon dioxide pressure despite adequate treatment at night, if they have symptoms of dyspnea during the daytime, or if they have frequent pneumonia due to cough insufficiency. So once patient reaches one of these criteria, it is always beneficial to start thinking about adding a few hours during the daytime of non-invasive ventilation to improve their daytime hypoventilation. Unfortunately, a lot of these patients will continue to progress and they might require tracheostomy. So any patient who starts having difficulty clearing secretions, if they have the NIV, which is no longer sufficient despite all the attempts, all adjustments of pressures, monitoring of the download, making additional adjustments, their carbon dioxide level continues to rise, or patients continue to have symptoms, or if patients require mechanical ventilation after an acute illness, so they get sick in the hospital, they get intubated, and then we are unable to wean them off the ventilator, so they often resort to tracheostomy. And some patients also might require the NIV for more than 16 to 20 hours. And at that point, we should really start talking about tracheostomy. It's very important, depending on the disease that they have, that we start discussing also about the goals of care and how these patients would like to proceed at this point of time. Again, we talked about ventilatory failure, cough failure, and swallow failure. So the next item we're going to be talking about is the cough support, which the cough assist devices, which basically simulate our actual cough mechanism, which, as we said, there is an insufflation or inspiratory phase. There is also closure phase where you actually build the pressure, and there is the exsufflation or the forced exhalation phase. Very effective cough assist devices, and they have shown to reduce hospitalizations and reduce the risk of respiratory infection. Secretion mobilizations, I'm sure all of us are familiar with the high frequency chest wall oscillation, which can be used for hospitals. Sometimes we use the intrapulmonary percussive ventilation, and they actually are more appropriate for patients who continue to suffer from atelectasis and excessive secretions, and they cannot actually mobilize them. So they will be the perfect candidates to start using this. Something very important that I see not infrequently, that patients will be started on vest therapy before cough assist. And that basically comes from patients with bronchiectasis and cystic fibrosis, because these patients, we are all comfortable to start, or actually we all are used to start them on vest therapy to clear secretions. However, these patients with bronchiectasis and cystic fibrosis, they have normal muscular strength. So they do not have a problem with their cough. So their cough mechanism is intact. On the opposite side, the patients with neuromuscular disease, they have problem with the cough. So it is recommended that those patients receive non-invasive ventilation first, followed by cough assist, or simultaneously, before they are considered for vest therapy, because you can mobilize secretions, but they do not have the strength to cough. So always cough assist should precede the vest therapy or the secretion mobilization technique. Again, I just put this as one of the society guidelines for the Duchenne, and as you see, a lot of the muscular dystrophy diseases, they have society guidelines that tell you how to monitor them and how to monitor the respiratory complications. And I would like to refer you to these guidelines when dealing with specific diseases, because a lot of them are out there and they're available for everyone. And with that, I will end my lecture, and I will be happy to take any questions. And thank you so much for your attention. Thanks.
Well, good morning, Dr. Mina. Thanks so much for joining us today. It was a really great lecture, and I'm glad to have you here live to take some questions.
Thank you.
Before we jump into the questions, there have been a lot of submissions on the chat feature in the platform asking about how to ensure that you get your CEUs and that you complete the necessary questionnaire. You do need to be live in the platform viewing the video feed for 30 minutes for that to pop up. However, if you go to the lobby in the portal, you'll be able to access a SurveyMonkey questionnaire to be able to complete your questions to get your CEUs. So just some housekeeping there. But Dr. Mina, again, thanks so much for joining. We do have a few questions, so let's just jump right in. First question that we have, what do you tell the patients about when and why a bi-level is appropriate versus a ventilator?
So that's a very good question, and we get this all the time. It really depends on the severity of the disease or the stage of the disease at which they present. So if I see someone with just a borderline decline in the respiratory function, and they basically are not at the advanced stage of the disease, I sometimes decide to start with a bi-level. If I feel that the patient has one of the diseases that are very well known, like for example ALS, to have deterioration of the respiratory system very quickly, then I prioritize getting the NIV first, because that basically will adapt more, will have more durability, will have the backup battery for those patients when they decline. Sometimes also the insurance criteria and the patient's characteristic can dictate this, because we know at this point of time there is no compliance associated with the NIV. So if I feel that the patient will take time to adapt to the device, then maybe an NIV is good, so you can have like gradual adaptation versus you get locked to the compliance when you deviate and go to basically when you start using the red devices or the bi-level devices. But in principle, both can do the same, except if you have more advanced disease, more rapid progression, then the NIV will be more viable or better option for them.
Great, that's helpful. And on a similar topic, how do you look at these treatments as it relates to the pediatric setting, and what other considerations should be made for that?
I think the society guidelines for Duchenne, for SMA, for most of those diseases, they actually have the same, similar, almost same guidelines for adults and pediatrics. The only difference is, which I don't treat pediatrics myself, but it might be difficult to test, the pediatrics PFTs and do the pulmonary function testing. So we use other clinical parameters. A lot of the pediatric population, they actually go also to the sleep center to do those in the sleep center, because they need a lot of coaching and training. And we try to kind of titrate their bi-level devices there. Also, we have to keep in mind, not all the devices are approved for all ages when it comes to which type of the device you have to use. So principle, they have similar guidelines. They need to have nocturnal ventilation followed by daytime ventilation, followed by cough assist and respiratory clearance assistance. It's just we modify it depending on which devices are approved for pediatrics, what age, and what's the available support for these kids at home.
Great. Thanks so much, Dr. Mina. We have about a minute left, so just a quick question. Can you just talk about the importance of partnering with the DME in providing these services and what you expect out of them?
Oh, absolutely. Basically, our success depends on the success of all the circles of the chain, starting from patient, physician, respiratory therapist, DME, and then it's a closed loop. So without really good, reliable DME that can basically honor the requests as soon as possible, with the expert or experienced respiratory therapist in these devices who can service the patient, who can explain to them how to use it. We only see them just, every once or, every 1 or 2 months, and then later on every 6 months, but they actually get in contact with the DME more frequently than that. So certainly a closed loop communication between DMEs and physicians and patients will make a huge impact in the success of the therapy. So certainly it's an important participant basically in this, loop.
Well, thank you, Dr. Mina, for that and for partnering with Medical Service Company in this event. We're thrilled to have you, and thank you again.
Thank you so much, Josh.